Good. Thank you so much, Dr. Stevens and Dr. King, for giving me this opportunity to speak with you and be a part of this lecture series, which I have never participated in before. So thank you so much. I have been a clinical assistant professor at Stanford in the pain division, I believe, since 2007. You can find me there on most clinical days, either doing procedures or seeing patients. I have many interests, but I agree with what you had mentioned in the introduction. I have a vested interest in musculoskeletal medicine and also electrodiagnostic or EMG testing, which I do both of at Stanford Pain Clinic. In my experience as a pain management physician over the years, there's some very common questions patients come in and bring to me that I'd like to kind of go over today and my experiences with pain medicine and musculoskeletal medicine. One of the most distressing things when people are in chronic pain is often not finding what they believe is the correct diagnosis or even a diagnosis. So many times, even if patients have been suffering with chronic pain, they come to me with a basic question of what's causing my pain. And even though that can be a very simple question, the answer is often very complicated. So I'd like to spend a few moments on that question that I often hear from patients. We, as pain management physicians and clinicians and researchers, have a very specific definition of what chronic pain is. When I started my education, we defined chronic pain as any pain greater than 6 months. Through the years, that guideline has actually changed, and we now distinguish chronic pain from acute pain by a 3-month window, meaning any pain that you're having greater than 3 months, which doesn't seem like a long period of time, comes under the realm of chronic pain. And we'll get into this description and why it's so narrow and what that really means for patients and patient care. I give this lecture not just to patients, but also to my fellows who are learning the subspecialty of pain, of what compromises pain in a human body. Through the years, I've had many complicated diagrams and ways of thinking of chronic pain. And what I've come to realize and through research and my own personal experience in clinical management of pain is I can really, and most people can categorize pain really in 5 categories. Bone, I call it 5 causes of pain. One of the basic causes of pain is bone. If anybody has had osteoarthritic changes or a fracture, you know that bones can be a very specific cause of pain and can cause significant amount of dysfunction. Another cause of pain, which we experience on a daily basis, whether we're moving functionally or not functionally, are muscles. My third category in my head that I keep about chronic pain is ligaments and tendons. And if anybody's ever had an ankle sprain or an elbow sprain, you know how painful that can be, even if there's not a fracture or a tear of those ligaments. What are tendons and ligaments? Simply put, tendons are cartilaginous structures that hold bones to muscles, and ligaments are cartilaginous, fibrous structures that keep a joint together or keep bones attached to bones. My fourth category is a big category of pain that pain management physicians keep near and dear to their hearts, and that's nerve pain. Anything from pain with the sciatic nerve to a carpal tunnel injury are considered neuropathic or nerve-related pain problems. But, our biggest processor and our biggest nerve, as I like to call it, in our body is our brain. And Dr. Stevens and Dr. King obviously deal with that aspect as much as I do for chronic pain. And then we also talk about All of these 5 causes of pain, brain, nerves, tendon, ligaments, muscles, and bones, as working together to keeping you functional, but also in some sense, they become a part of that chronic pain picture that patients come in with. It is very rare in the clinical setting that I see a patient walk in purely with one of these 5 categories of pain. It may start off as a twist in your ankle or a sprain in your back, but it quickly becomes something that affects all of these 5 categories. And that's where the real challenge comes to find the diagnosis that is causing you your pain. As a patient or a person without pain, you know that daily routines can challenge any of these 5 components of your body. So you may have some muscle aches one day, but then the next day, if your sleep is poor and you twist and turn incorrectly in bed, you can have some tendon sore. You could be lifting a heavy weight and walking, and you feel this sudden rush of pain down your leg, and we sometimes call it a radiculopathy or a sciatica. All of these nuances of pain can wax and wane from day to day, from hour to hour. And that is really the challenge of giving you one perfect diagnosis of pain. Sometimes people come to me, for example, with osteoarthritis. That could be osteoarthritis of the knee or the hip or the shoulder. And instantly, we all want to use that one reason to explain the variable aches and pains and sources of discomfort for the patient. But sometimes that's just a simplification. It may start out with an osteoarthritic joint, but it may go into something that we call chronic pain. It took me a long time to figure out why this discussion about the definition of chronic pain was impactful. Excuse me. And what I realized is the differentiation between a pain that is less than 3 months versus a pain that's greater than 3 months is really your nervous system, your central processing system of your body or your brain, which incorporates the spinal cord and your brain. In research done by my colleagues at Stanford and in other departments all over the country and the world, what we found about chronic pain is that the central nervous system changes the way it processes pain after and within about 3 months of having a pain. Now, what does that mean? For example, if you've been suffering from an osteoarthritic knee, and the knee has been causing dysfunction in walking or sitting or moving, eventually, what we believe is that not only is the knee swollen or hot to touch or difficult in movement, but we now think that the patterns of pain regarding the knee have now imprinted into the nervous system, your brain and spinal cord, where there has been a central processing change in how your knee pain is being processed. Some people call it inflammation, right? The difficulty with using the word inflammation or an inflammatory process is often we think of inflammation as something is swollen. If I bump my elbow and my elbow is red and tender and swollen, I call it swelling or inflammation. that isn't necessarily what is happening in our central nervous system. In our central nervous system, after about 3 months, these inflammatory neurotransmitters are now being released, even though the pain origin is in our knee. And that's what is the difference in a very simplistic way. And it's obviously a little bit more complicated in research and how we look at it in the lab. But that's the real difference between acute pain and chronic pain. So, what are these neurotransmitters that are evoking changes in our nervous system? The central processing, there's many chemicals we talk about. I'll just name a few which have been heavily researched. Substance P, cytokinins. These substances are causing changes in our central nervous system, even though the offending agent is a peripheral joint. So now we have a peripheral or a specific joint that is in pain for greater than 3 months. And that is now looping back around and causing a change in our brain and spinal cord and how we're processing pain signals. So, when a patient comes into my clinic and says, "Hey, Dr. Gowda, I need to know the cause of my pain," it is a simple question, but like I said, the answer can be extremely complicated. We talk a lot with our colleagues, Dr. Stevens, Dr. King, about how to manage not only the peripheral injured joint or muscle or tendon, but how do we change this loop of pain that has now been aggravated and insulted, causing significant difficulty for patients to manage? And that's why, for example, surgical intervention, one surgery, one needle, one injection, one medication may or may not help chronic pain, which is very different than acute pain. For example, if anybody has ever fractured a bone, that's a very good example of acute pain. You have a bone that has been fractured, that area hurts. Hopefully, with the appropriate surgical intervention or casting, that bone mends and the pain eventually goes away. But if it doesn't, again, that goes now in the realm of chronic pain if it lasts greater than 3 months, because now we think that the central nervous system has been activated also, not just that bone. That differentiation and understanding of chronic pain versus acute pain, and specifically acute musculoskeletal pain, is extremely impactful for how we treat patients and how we treat patients, hopefully, with the gold standards of care that are required to help them gain and rebuild their bodies. The other questions that often come up in my practice is not only what is my diagnosis, but specifically in musculoskeletal medicine, and it's exactly what it sounds like: musculoskeletal muscles and tendons and the skeletal system. Which area is really my biggest problem, and what are some strategies to help these areas of pain? I still see acute pain, meaning pain less than 3 months, because even if you do have a type of chronic pain, you can still have a sprained ankle and you can still have an acute sprained elbow. And those are treatment options that I provide for my patients as well. But more than that, I think what I truly have seen in my practice is a balancing act that patients do that they learn through time, testing, and trialing to help the pain modulation from going too high to too low and learning what actually helps them. It is interesting to me that the longer I treat patients in the clinic or have access to patients, usually in the realm of a year to year and a half, that's where we're able to try different things to figure out what is the multidisciplinary treatment options that may work for you. But that requires time. And the most successful patients in helping improve their function are those patients that have the ability, the patience, unfortunately, to make trials and errors with their treatment protocols. And we work very closely with our colleagues in the pain psychology department. And the most successful patients in our clinic are those that I believe use all of our resources to help guide them through challenging days and months. So I'm going to go over a couple of treatment options that I'm sure most of you have heard of. Some of you have tried, some of you have had great experiences with, and some of you have not. But to me, these are some basic things that often are overlooked, but can be very effective, especially when used in combination. One of the biggest things I tell my patients, and I know this is a challenging topic, and this topic will be addressed many times and before and will be hereafter, is the goal for appropriate sleep. I say often to my patients that chronic pain and sleep deprivation kind of go hand in hand. Which came first, the chicken or the egg? I'm not sure, but they definitely are cousins of each other. And I often tell patients that if I can't get you to sleep, or at least work on your sleep, I'm going to have a hard time helping you with your pain and functional improvement. Now, that's easier said than done. There are many limitations for patients with pain and sleep, including getting to sleep, staying asleep, getting up while in pain, not able to have restful sleep, even though they may get the hours of sleep in. This whole problem, this group of problems, is in the realm of sleep hygiene. There's hundreds of books and resources that are out there for you. But I will impress upon you that in musculoskeletal medicine, what I found is patients often complain about cramping, almost like Charlie horses in the middle of the night in different body parts, and difficulty with feeling rested when they wake up. For those of you that don't have a primary care physician, please get one if you can. But those of you that do have a primary care physician, one of the things that I recommend almost to, I would say 95% of my patients that are having habitual issues with sleep is to get a sleep study. I have noted that through the years, sleep studies have become much more effective in diagnostic purposes, if you have any other reason to have difficulty with sleep besides pain or factors of sleep hygiene that we can work on. But getting a sleep study can help understand how many times you wake up at night, what causes you to wake up at night, if there's any breathing issues associated with limitations in sleep, and your sleep pattern. So it's not just about having sleep apnea and being analyzed for that. It's really about how you're sleeping and what your cycle looks like. There are home kits now that are very advanced that you can use. And then there's also sleep labs that you can go to. Most insurances will definitely cover all of these expenses. So please look into that. The second thing I tell my patients is if you are suffering from difficulties with sleep, and it does feel like musculoskeletal issues, tendons and ligaments and bones are hurting, a simple thing to do if you haven't tried it is an Epsom salt bath or soak, whether it's your hands or your feet or even your whole body soak, followed by just slight stretching of the areas that are hurting you before you go to sleep. I have to remind my patients that when we all sleep, we sleep in a very dependent position, meaning our wrists are flexed, our feet are extended, and that is how we sleep. When we sleep on our side, we can make our trapezius hike in one area. People often ask me about pillows. Is there a specific pillow or mattress that I recommend? The only recommendation that I have for pillows and mattresses is to change them often, and make sure that you have a position that is neutral, meaning your neck and your spine is as elongated as possible. Often I know we recommend for side sleepers hugging a pillow, putting a pillow between your knees so that you can attain neutral position. The other question I often get for sleep is about caffeine, which we know can, in some patients, affect you even 6 to 8 hours and longer for your sleep cycle. I get asked about other sleep hygiene issues such as the TV, reading, lights, books. And again, all of these things affect patients' sleep, which is extremely impactful on how you feel. I'm sure many of us who have had some difficulties with insomnia and getting to sleep feel like we almost have the flu the next day and you're just kind of achy all over and you're not sure what exactly happened. It is often our sleep patterns. So that is something we really need to address with patients, and we often do. The data on sleep medicine is pretty poor. I often don't get a lot of wins with sleep medications, and that's because, as Dr. Stevens and Dr. King will tell you, sleep is such a multifactorial issue that if you're not doing the right things to fall asleep, it is nearly impossible to be rested. I often give the example of parents or grandparents or aunts and uncles who are helping young children foster good sleep hygiene to kind of do those same things for yourself to help with sleep, right? We put children in pajamas an hour or two before that they need to go to bed. We get their brain engaged of the process of sleep by brushing their teeth, giving them some water, putting them to sleep in a cold environment around 68, 69 degrees. We get them to relax by reading a book, relaxation techniques. And those are the same sleep hygiene techniques that I want you to think about when you are putting yourself to sleep. And I think that is something we can do for ourselves besides the medical changes we can make for you to help you in sleep. The other question I often get is about physical therapy and exercise. It is very difficult when you are in pain to hear a physician say, "Are you exercising? Are you in physical therapy?" Because sometimes it is the actual physical therapy or exercises that you're doing that is causing flares. And patients often ask me, am I making myself worse by doing certain exercises? Am I causing more damage? And what do I do about my anxiety about making things worse? Because the next day after I go to physical therapy or I do my home exercises, I feel 10 times worse. So, one of the things we do at the pain clinic is a physical therapy evaluation with our physical therapist and by our physicians to see what specific things we can help with and also help you understand the concept of pacing. And by pacing, I mean what exactly you need to do in your routine to not overdo and then be out for the next day or 2 days where you're actually now being more deconditioned because you have done X, Y, and Z the day before. Those things really have to be spoken about and addressed. And often it takes multiple months to adjust your home exercise program or your physical therapy treatment protocol before we can engage in appropriate movement. And again, the fear of movement is an extremely limiting process that is very natural to patients with chronic pain. I often work with Dr. Stevens and Dr. King on helping patients with exactly that, a fear of movement, because in their repertoire of being in pain and going to many physical therapists or doing many types of exercises, they have spasmed or they have had an extremely poor outcome, which makes them fearful for moving forward. And that is very limiting. I tell my patients often exercise is not just to help you with your current problem, it is also to keep you conditioned in your other body parts so that we are not having changes there because of your chronic pain elsewhere, right? We're all connected. Our left side of our body is connected to the right side. When the right knee hurts, we can sometimes put too much pressure on the left knee. And so we have to look at our body in a holistic way and understanding the psychology of exercise and what needs to be done is just as important as the exercise itself. Excuse me. So fear-based movements that are restrictive, lack of pacing, and also the lack of stretching and appropriate stretching can be very difficult to overcome without some specific guidance. I always talk about exercise as a yin yang, back and forth routine of stretching with appropriate strengthening. It is very difficult to strengthen a body part that is extremely tight and which has not been stretched appropriately. I also talk about overstretching ligaments and tendons can lead to injury causing less strength. So stretch and strength have to be appropriately done for regions of our body to help move us forward in an effective way. The biggest issue in physical therapy or home exercises is our inability to put a routine together that allows us to increase our strength without injuring, and also build a conditioned system that can now take on injury without causing significant pain. That routine is an extremely challenging routine because often when we have a procedure or a medication or a good night's sleep, what we do is we overcompensate the next day by doing things that we haven't been able to do, whether it's gardening, going on your bike, hiking, walking, and then we have a setback, which again, not only can be very difficult to take physically, but also very difficult to take emotionally because you think you're having a setback. And we often in our clinic go over your workout and your physical therapy protocols together, and also rely on our psychology team to help guide us with patients that are having these specific difficulties. The other questions I get asked often is about very specific things like heating and icing. I appreciate both. However, I find that icing a joint after some working out is a much better process for it to be helpful in your pain. Some patients are having difficulty with tolerating ice versus heat, and then they use both, but about 5 to 10 minutes of icing 3 times a day is often what I recommend. Unfortunately, whether it's ice or heat, I have seen thermal burns on patients' skin if patients sleep, for example, with a heating pack or sometimes even an ice pack. So I will caution you regarding this. The last thing I'll talk about with physical therapy is one of the most underused physical therapy protocols that I've seen, and which most insurance pay for, is aquatic physical therapy. Aquatic physical therapy is more than just getting into the water and swimming. Aquatic physical therapy are groups of physical therapists who choose to do aquatic physical therapy, often have an indoor pool. Your physician can write an aquatic PT prescription, and then the physical therapist will take you in the pool and have you do groups of exercises in the water. The goal is to have a little less resistance on your tendons and muscles, and to have improved motion and improve range of motion without gravity pulling on you so much. Like I said, most insurances pay for aquatic physical therapy, and I think it's a great asset to be able to do this along with your land-based physical therapy. Again, pacing, understanding your fear of motion, and making sure the exercises are done correctly is why we often send you with a physical therapist to do aquatic physical therapy and not just initially on your own into a pool. What I have also thought about a lot and discussed often with patients is we have these 5 core elements of causing pain: nerves, muscles, tendons, ligaments, bones, and then your brain. So patients often say, so Dr. Gowda, if I just relax and I do breathing exercises, my knee pain, my arthritic knee pain will get better. And obviously that's not what I mean, and that's not a literal interpretation of the nervous system and how it works, but it is a good question. I was in a painful procedure myself, and I was conscious for the procedure many years ago. And I remember the physician was unable to move forward with the procedure because my blood pressure had soared up. I was being monitored for this procedure. And spending so much time with my colleagues in the pain division, specifically Dr. King, I started some breathing exercises. And in the procedure room itself, about 5 to 10 to 15 minutes passed as I was doing these breathing exercises, and I could see my systolic blood pressure and my diastolic blood pressure coming down without medication. And I had never experienced this before. You know, we don't often, I don't think I've ever put a blood pressure cuff on a patient and asked them to do some cognitive behavioral therapy or relaxation techniques or breathing techniques and then monitor their heart rate and blood pressure. I've read about this. I understand this is possible, but that really changed, really systemically, how I approached my pain and my fear and anxiety that is associated with pain in a very graphic presentation that I was surprised and shocked about, and also thoroughly excited about. And so, do I think your knee pain will go down just by breathing exercises? I don't. But I do know that if we use cognitive behavioral therapy along with other techniques, could we decrease the cortisol production in our body, these inflammatory processes that are happening in our central nervous system, to make an effective and acute change to a chronic process? I do. I do. So, whatever techniques that is, or if you come to us to learn some of these techniques, I don't think they're invaluable. I think they're essential to being able to tap into all of these resources that are required to be effective in chronic pain management. It's almost 6:15 right now, and I'd love to be able to answer any questions or discuss any comments with you all. And thank you so much for your attention and listening.